Last week, I was able to share you part one with my lung ultrasound 2022 update. Now what I'm going to do is share with you part two, where I talk about pneumonia, both viral and bacterial, specifically talking about COVID-19 pneumonia. And it's really, there's not a huge difference, just a little thing about the clinical scenario, obviously, because that's how we do all ultrasound in general. We don't just use in isolation. We actually take the patient in front of us, do the ultrasound, put the two things together, and then figure out what is the most likely thing with our patient. Sometimes even add a third thing, some extra things like lab work, maybe some further imaging. It's all good. Ultrasound's just a piece of the puzzle. It's an arrow in your tool chest or a tool in your quiver. Now, for this video, what we're going to do is we're going to show you part two. Like I mentioned, check it out, and don't forget to check out three things. Check out courses.coreultrasound.com. We have a question bank, we have fundamentals. You can also check out our new course, which is actually going to be in person in San Diego. There's the URL right there. And then don't forget to check out the Ultrasound Leadership Academy, where we can give you a year-long fellowship, whole year-long curriculum, as well as one-on-one hangouts. Check it out. But before you check those things out, here is the
That's
video.
not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
All right, let's move on to our penultimate topic, and that is going to be the diagnosis of pneumonia. Now, with the other topics that we discussed, I didn't really go into too much evidence because first off, there's a lot of it. And second off, I think a lot of us understand that our physical examination and even the chest x-ray is not that accurate. If you look at the pneumothorax literature, the pneumothorax is, an x-ray is probably as specific as ultrasound when you use a CT scan as a gold standard. But when you look at the sensitivity of a supine x-ray is like 50%, whereas the sensitivity of a ultrasound looking for pneumothorax is between 85 and like high 90s%. So it's significantly more sensitive. Same thing with cardiogenic pulmonary edema, same thing with pleural effusions. With pneumonia, I think this is something that I'm going to discuss a little bit more because we're so used to getting that chest x-ray to rule in and rule out that pneumonia. The problem is when you look at the literature, the sensitivity for an x-ray, and that is using either discharge diagnosis or a CT scan as the gold standard, the sensitivity of an x-ray is pretty poor, right? It ranges between 45 and 75%. And when you look at the sensitivity of ultrasound, you see that the sensitivity ranges from about 80% to 100%. So the worst that ultrasound does is better than the best x-ray can do at ruling out a pneumonia. Specificities are pretty similar, but the sensitivities are significantly better, which that's actually what I'm more concerned about in the emergency department. I want a very sensitive test rather than a specific test. I mean, I like both, but sensitivity is better. Now, what about these patients right here? The dehydrated, immunocompromised, and the elderly patients. These are the ones that x-ray does the worst at, right? I remember when I was a resident, I would hear like, I think that this patient might have pneumonia, but I'm going to give them some fluids to see if their x-ray fluffs out, right? Which is like ridiculous, right? That you have to do an intervention for a test to be more accurate. It's crazy. And I'll tell you that ultrasound does good even in these patients. This doesn't actually affect the accuracy all that much. Now, there is some studies that actually back this up. I don't know if does anybody work in like hospice or palliative care at all? I mean, I don't, but I feel like I dabble in it because a lot of my patients happen to be within that category, right? So this is the Rockford Clinical Frailty Scale. And it's kind of nice because it kind of walks you through kind of an objective measure of if a patient is frail or not. Basically, anything greater than about 4 is considered frail. Now, I love this study here. This is a study that was done in Italy, I believe, and they took 169 patients who they wanted to see if they had a pneumonia or not. Got x-ray, got the ultrasound, and it was in a geriatric ward, so it was all elderly people that were a little more on the frail side, and they had this cutoff. 5 or more they considered frail, and you can see here it's basically like they need a walker to get around. 4 or less is somebody that is fairly active on their own. And they looked to see what were the sensitivities of x-ray and ultrasound in different categories, 0 to 1, 4, or greater than 5. And you can see here how, look at this precipitous drop in the sensitivity of that x-ray in this study. Went down to 33% sensitive in the most frail patients, the one where arguably the diagnosis matters more. And if you look at ultrasound, yeah, it went down. It went from 96 to 89%, but 89% sensitivity on a bedside test is really good. And when you compare that to what the kind of gold standard is, which it definitely shouldn't be, it's CT scan should be the gold standard, but kind of what I think many of us think the gold standard is of X-ray, it does very poorly in general, and especially in the sickest of patients. So this is something that I think kind of shows even more the benefit of using that ultrasound. The other thing is people don't always agree on a positive X-ray or not, right? When you look at the kappa values of X-rays, now the kappa values here are basically if you take one radiologist, take another radiologist, they look at the same X-ray, how often will they agree? A number probably at 0.6 to 0.8 is an okay number. 0.8 and above is great. And you see here that X-ray has pretty poor kappa values. And if you look at ultrasound, so it's two different people looking at the same ultrasound, they agree with a very strong correlation. So 8.9 and 8.3 in these two studies. Now let's talk about exactly how we diagnose it. Hopefully, this image looks familiar-ish to you now. We have a rib over here, we have a rib over here, and then right here is that pleural line. Now this is a pattern recognition thing. When I'm scanning, I actually scan pretty quickly throughout the entire lung because it does. If you are focused and you spend too much time on like one rib space, the lung examination for pneumonia it'll take a long time. And so the way I get around this is just focusing. My mind looks at this, and this is what normal should look like. This is how the entire thorax, each hemithoraces, are supposed to look like. So focusing on this image, what I do is I have the patient sit up or lay on their side if they can't sit up, and I look at the posterior aspect of the thorax first. I'll identify where the lowest portion is by identifying, you see right here, this is the kidney, this is the spleen. So I'll find that area in the back, and then I'll bring my transducer up to make sure I'm on the very bottom of the lung actual cavity itself. And I'll basically, as soon as I've found that spot, the lowest area, I'll just lawnmower side to side like this, all the way up. And remember, the lung actually goes all the way up to the base of the neck. You can't see through the scapula, so you notice I'm taking kind of smaller sweeps up here as I go through, and you can see that I'm still able to see there's rib up top right here with the shadow, and there's rib with the shadow right there, and then in the middle I'm still seeing some pleural up there. So still, you got to look in between the scapula and the spine. And when I'm doing this examination, I sped it up here, but when I'm doing this examination, I'm not like doing my history, doing my physical examination, going to my desk, ordering labs, coming back with the ultrasound. What I'm doing is I have the ultrasound machine with me. I usually actually have my ultrasound in my pocket. And as I'm talking to the patient, as soon as I see that the complaint is dyspnea, shortness of breath, they have a fever, right? I'm going in there with my ultrasound machine, and as I'm talking to them, I'm doing this scan. So it actually isn't taking me any more time. Now, after I've done that, then I'll go ahead and look at the other zone. So that's the middle zone, or kind of like the armpit area. And I'll do the same thing, just scanning back and forth. And the whole time, I just want to know, does it look like this, normal, or does it not look like this? And then of course, I'll also do the anterior wall. Now let's say I identified an abnormality in that area. What I'll do is I will then turn my transducer to be parallel with the ribs, just in the intercostal space, and I'll just kind of fan within that space to look at that a little bit more clearly. And then of course, look at the anterior wall as well. Now there are a lot of different signs that have been talked about for the diagnosis of pneumonia. These are all of the things that are associated with the presence of pneumonia on ultrasound. We already talked about pleural effusions. Now, this is not something that I'm using, obviously, primarily to diagnose a pneumonia. I'm using this as something that happens with a pneumonia. So I'm not going to talk too much about this, but it has been associated with it. These are not my favorite, especially for bacterial pneumonia, because there's so many other things that can cause this. But this can be present, these B lines, pleural line abnormalities, and subpleural consolidations, which we'll talk about. These can all be present in the periphery around a lobar pneumonia, or they can be present at the beginning as a pneumonia is like starting out, and they are the way that you diagnose viral pneumonia as well. Let's talk about these right here, B lines and pleural line abnormalities. We've already talked about B lines, right? They're the vertical artifacts that move with respiration, extend all the way down to the bottom of the screen. And sometimes you're gonna see this over here. You see this like super lumpy, bumpy kind of pleural line. You see how up here it's like relatively crisp, and over here it's not, it's super like jagged. When you see this jagged pleural line, it's much more likely to be an inflammatory process, just so you know. Now, all of these things here can cause B lines and pleural line abnormalities, which we've already discussed. I want to talk about subpleural consolidations, which I could talk for like 2 hours just on what subpleural consolidations are, how they're formed, what do they mean. I'm just going to spend like 2 sentences by saying that we all say subpleural consolidations, but it's really like kind of like a misnomer, because anything that you can see with lungs is subpleural. It's all beneath the pleural. So that's silly to me. And a consolidation is a consolidation. When we say subpleural consolidations, what we mean is we mean a small kind of focal consolidation that is usually less than 3 centimeters in diameter. That's usually what we mean when we say subpleural consolidation. And this can be present in a lot of things. Now this right here are 2 examples of subpleural consolidation. You see how they're just like little bits of hypoechoicness right here? It's a little small consolidation right here. Now, when I worked in Kentucky, probably the most common time that I would see these subpleural consolidations was actually in septic emboli from endocarditis. I probably had an endocarditis every other shift. Like I'm diagnosing for the first time endocarditis, probably every other shift. And this is honestly most of the time how I would catch it. I would have a young person that came in, they had taken 2 rounds of a Z-Pak and they still like had a cough and still had a fever. They were young, they had track marks. I'd look for these, I'd find them, then I'd look at the heart, I'd see that big goober on the tricuspid valve and admit them for endocarditis. But besides that, there are a lot of other things that can cause it. You can have septic embolism, a PE, a regular like blood pulmonary embolism can actually cause these subpleural consolidations. Pulmonary contusions, pneumonia, arch, malignancy, all of these things can also cause subpleural consolidations. Now, I talked about those first because those are the less specific ones. Now I'm going to focus in on the ones that usually I'm using to diagnose a bacterial pneumonia. We'll start off by talking about fluid bronchograms. We're all familiar with the word bronchograms, right? We see them on x-rays. We maybe even hear about them on CT scans. What bronchograms are is basically you're seeing the bronchi, the small airways, because the consolidation around them is letting you see the air within that consolidation, right? It's very similar with ultrasound. What we're able to do is when you have a huge consolidation, you can actually see small blood vessels and small airway in the lung. In a normal air-filled lung, it's air-filled, you can't see the tissue. If you have a big pneumonia or big consolidation, you will now be able to see actual lung tissue. And this is what it looks like. So it looks like a bunch of kind of like sonographic gibberish, right? But remember, what we're supposed to be seeing here is we're supposed to be seeing that pleural line with a bunch of A lines. Once we see actual structures here, that is when we get concerned that the patient has a consolidation. Once we see tissue, it's abnormal. Now let's focus in on the little areas right here. You see these little divots here? There's like these parallel lines right here. I can see a lot of white things. These are all bronchograms. And you can actually see that there's a little tube. It's hard because of the lighting, but you can see it's almost like a little tube right there. And that little tube, it's a fluid-filled airway. This is what a fluid bronchogram looks like because you have fluid within the bronchi. Now, one thing that it could be is it could be a blood vessel. In fact, if I put color flow on this, you can see that there's a lot of color flow on there. You don't really, in my opinion, don't really need to tell the difference between a fluid bronchogram and an actual blood vessel in the lung. And the reason for that is because if the lung is so consolidated that you can see a blood vessel within the lungs, that's probably a pneumonia. And telling the difference between a blood vessel and a fluid-filled bronchus doesn't really matter because in both situations, you have a super consolidated lung, and that won't actually change the fact that you have a huge consolidation. So I don't really care that you can't really tell the difference between the two, but if you want to, you can throw color flow. Now this is the one that I use the most, and this is for bacterial pneumonia specifically. These are air bronchograms. Now remember, this is kind of our anchor image. This is what the entire thorax should look like. We have the pleural line up here. We have a rib with some shadow over there. We have a rib with a shadow over here. And then we have some A lines, these horizontal reverberation artifacts. This is normal. Now, let's say we look at the exact same area on a different patient and we see this instead. This looks abnormal, right? This is very much different from that previous image. All of these white things in here are all air bronchograms within a massive consolidation. Now, these right here that we're seeing, these are what we call static air bronchograms, meaning that they are not moving they are not moving apart from the actual lung tissue moving. So you'll see those white things move as the lung moves, but if they kind of stay within a fixed space and move with the lung, that is considered a static air bronchogram. What we can also see sometimes is this. Now I'm super zoomed in here. I'm already identified the consolidation. I'm using a linear transducer now because it's a higher frequency. It gives me a better resolution image. You see these white things that are moving up and down, back and forth? You see those things right up there? Come on, clear. Those are what we call dynamic air bronchograms. As they're moving as the patient either is getting the respiration or as the patient is breathing on their own. These little white dots that are moving up and down, these are actually representative of little bubbles of air or pus within the airways moving as the patient tries to breathe. These are dynamic air bronchograms, and these are thought to be highly specific for pneumonia. Here's another case right here. You see these white things over here? Little white things that are moving? My clicker's kind of out of batteries here. So right here, those are dynamic air bronchograms. As the patient breathes, we see them move back and forth. This is supposed to be air, pus in the airways. This is a pneumonia. Do you guys see that beady thing down below? I think that is right there. Use my actual mouse here. So this right here, this was actually a patient that came in. I was highly suspicious for a pneumonia. They looked like a pneumonia. The x-ray was negative, and I stuck the transducer in the left armpit and angled it a little more anterior. This is one of those classic retrocardiac pneumonias that x-ray often misses. This is a pneumonia right behind that heart. Now, it's very important to not just look at one spot on the thorax, see that it's negative, and then say like, there's no pneumonia. This is why you have to scan the whole thing. This is a patient that came in with shortness of breath, cough. He had a history of COPD. What do you guys think about this? Would you call this a pneumonia or not? In this one spot, we have pleural line, A line, A line. We have a rib shadow, rib shadow. Do you guys see any consolidations here? I sure don't. I see no consolidations on this one view. Now what I'm going to do is I'm going to move a little bit. I'm going to move down. What about now? Do you guys see an abnormality? We went from no A lines, now we're seeing a bunch of B lines. All right, so now we're starting to see that there's an increase in density. Now what I'm going to do is I'm going to move further down. I was in the middle lobe. I'm getting into the lower lobe right now. I was in the armpit moving down. And as I move further down, boom, I see a massive consolidation. This is a lower lobe pneumonia. We have a bunch of air bronchograms. We have B lines coming off of it right here. This right here is a sliver of a pleural effusion. So the patient has a parapneumonic effusion as well. This white line is the diaphragm. This is the liver right here. So this is a huge lobar pneumonia. So here is middle lobe, normal. We're getting down into the lower lobe. We're seeing some B lines, increase in density. And then we go down further, and now we're able to see that huge consolidation. A reason why it's so important to do a thorough examination when you're scanning these patients. This is this patient's CT scan. So you can see how it correlates. It's a pretty good correlation with pathology on our gold standard imaging, which is the CT scan. Here's another example right here. We have a rather big consolidation of a pneumonia right here. Here we have the spleen or liver. Spleen or liver look exactly the same. We have the diaphragm right here, and then we have a pleural effusion actually going up and around there right there. So this is a parapneumonic effusion. Here's another good example. This is both static and dynamic air bronchograms. We see these white things right here that are moving almost like a little, one of my ex-residents called it a pneumonia worm. It's like a little pneumonia worm moving back and forth. This is highly specific for a pneumonia. So here I'm going to zoom in a little bit more. Pneumonia worms mean pneumonia. Now, there's two signs that I hear thrown around a lot, and I don't really use them very much. They're called the shred sign and hepatization of the lung. Now, the reason that I don't really use these signs is you can use them. Like it's fine. I don't have any problem with people talking about these, but the shred sign, what they talk about is basically this area right here. You see this like kind of white line that looks kind of shreddy? They call that the shred sign. And the reason that I don't think that needs to be called a separate thing is because it's just describing the border of a consolidation. Like, I don't know why the border of a consolidation needs a separate name. It seems like too much. Like we don't need extra stuff if we don't need it. And then hepatization, all that means is that the lung now looks a bit like the liver, which it's true when you have actual consolidation of the lung, it does kind of look like the liver. But again, that's another like sign that just seems like it's an extra sign that we don't need. So I don't really use these, but hepatization means consolidation, and the shred sign means a border of a consolidation. Now, one big thing is this. the diagnosis or the differentiation between a pneumonia and atelectasis. You can't really do that super well on ultrasound, but here's the thing, like, you can't do it super well on any other imaging, right? Like, there are sometimes where you can say on CT scan that's definitely a pneumonia, but oftentimes, I mean, how many times have you guys gotten images back, X-ray or CT scan, and it says consolidation clinically correlate for pneumonia? I mean, I get that all the time because a consolidation is a consolidation. It can happen due to atelectasis, it can happen due to pneumonia, it can happen due to a post-obstructive problem, and it really depends on what the patient's doing in front of you. I will say that a dynamic air bronchogram, remember those pneumonia worms, are basically only seen in bacterial pneumonia, and the static air bronchograms, those fixed ones, those can be seen in both atelectasis and pneumonia. And it's another reason why you always have to remember that the ultrasound, just like any other test that you have, should not be used in isolation. Take everything together, add the ultrasound on there, and be a good clinician. Now, the last thing I want to talk about is this: bacterial versus viral pneumonia. Now, this is something that is pretty important, right? Being able to diagnose a virus versus a bacterial pneumonia, because the treatment is different, right? The prognosis is a bit different. And there are a couple ways that you can tell the difference. Now, with bacterial pneumonia, you will have that large consolidation, you will have those dynamic air bronchograms, you'll have those fluid bronchograms. With a viral, and unfortunately an early bacterial pneumonia, you will have all of these things: B-line, subpleural consolidations, pleural line abnormalities, and even those static air bronchograms in those small little spaces. The one thing that helps when I'm trying to figure out if it's viral or not is, of course, clinical picture. But bacterial pneumonia is usually in just one area of the lung. You definitely can have patients with bacterial pneumonia in a lot of different places. But for the most part, bacterial pneumonia is stuck in one area, whereas viral pneumonia is going to be just kind of all over. So that's kind of how I think about it. Now, this next slide is not meant for you to like think about right now because it's a lot. But if you want to, you take a screenshot. I'm also recording this. I'm going to put it on the website later. But this is just to kind of show you what signs can be present with certain pulmonary pathology, because it can be a little bit confusing. Now, I harp on this a lot because I'm not just a sonographer. I am an emergency physician. I'm a clinician who uses ultrasound in daily practice. I am not like, it's kind of like how I feel about Apple products. Like, I'm not like invested in Apple products. It's just Apple products work the best for like my workflow, right? For like my life, Apple products just happen to work best. If in your life, like Android works great, awesome. If something comes about that ends up being better than Apple products, the way that they all talk to each other, I'm gonna go for that thing. Like, I don't have any loyalty to Apple per se. And I'll tell you, I feel the same way about ultrasound. I have no loyalty to ultrasound. I like ultrasound because it helps me be a better doctor, and it helps me diagnose patients quicker. It helps me cause less complications when I do procedures. Once a tricorder comes out, I'm gonna abandon ultrasound and just do the tricorder, because if something's better than ultrasound, I'm gonna use that thing. But for now, for the technology that we have right now in 2022, I believe that ultrasound is invaluable. Like, there is nothing else for a lot of these pathologies that we have that is as good at the bedside than ultrasound. Now, big thing, this is it seems like it's chilling out, which is like, I'm so like happy about it. I remember thinking about how arrogant were we in 2019 to think like that's how like life was going to be for the rest of our life. Like, we would all just go to huge concerts, that we wouldn't have these like massive global shutdowns. Like, it's crazy to like think about it. And it's like the last like 2-3 years have just been like, it's just part of our life now. Like, it's not a good part of our life, it's just like a part of our life now. And we have actually been able to integrate ultrasound into the workflow of COVID-19. Now, before COVID happened, there was some research on diagnosing viral pneumonia with ultrasound, but I'll tell you that there wasn't a lot of stuff out there because, I don't know, like, we'd been dealing with flu for 100 years, and bronchiolitis, it does affect some people, but patients rarely die from RSV. Patients rarely died from influenza, right? So there wasn't a whole lot out there, but we have so much data on COVID now. And the findings are basically findings of viral pneumonias. They are B-lines, scattered B-lines, subpleural consolidations. The one thing that is interesting about COVID-19 pneumonia and ultrasound is it seems like the chance of your patient having a basal or pleural effusion with COVID is actually pretty low. So that's the one thing that is like kind of different that we're learning. But besides that, it just looks like scattered viral pneumonia. And you can't really tell the difference per se between COVID and flu, but these are some kind of sort of things that you can look for. Now, one of the advantages to using your ultrasound in the diagnosis of COVID is the fact that if you chest x-ray your patient with COVID, like that's a massive machine to have to clean, right? That's like a lot of things. It's like 2 extra personnel that now have to be in the room, and you are in the room because you have to examine them. When you use that ultrasound, you can actually keep it pretty clean. You can use your little cart-based machine, bring it in there, scan, clean it. It is easier to clean than a huge x-ray machine. But what you can do is if you have the ability to get one of these handhelds at your shop, you can actually stick them in a sterile sheath. And it doesn't have to be just the butterfly ones. This is a completely wireless transducer called Vave. And there's a couple of wireless transducers out there. And I tried this on actual patients. I'm just using Ziploc bags here that I just bought at Walmart. And I'm able to protect these and protect the patient. And they're much easier to clean than your bedside ultrasound machine, or the cart-based machine, or the x-ray. So this is one of the reasons why I think it works pretty well. So I kind of mentioned it. This is actually what COVID looks like. One of the things that you'll see is, you see how there's a lot of B-lines here, these vertical artifacts that extend all the way down to the bottom of the screen. We see these B-lines, but you see how it's kind of scattered? Like as I'm moving through that intercostal space, you'll have some regions where there's like a bunch of B-lines, and then you'll see a little section where there's not a whole lot of B-lines. This kind of scattered nature is something that is common in both COVID and in ARDS, because it's kind of like a similar picture to the lungs. And then over here is that subpleural consolidation that I was talking about. So you see here, there's this big kind of divot right here. This is a pleural line right here. We have like a B line right there, and we see a big divot right there. This is a subpleural consolidation and is more indicative of more severe COVID-19 pneumonia. The one on the left is just one of my gazillion patients that's on the ER, and that picture on the right is my lung in 2020. I had like quite a few of those scattered throughout my lungs. So you can easily diagnose this at bedside. Do we have any questions? All right, great. Thanks so much. So that concludes part 2 of my lung ultrasound 2022 update. I hope that you found it engaging, you found it a little entertaining, and what I want to do is I want to encourage you to reach out to me. Let me know if you have any questions or comments on it. You can send me a tweet, you can send me an email, you can reach out directly on the site or on YouTube. If you disagree with me or you have any other things to teach me, please let me know. I'm always down to learn new things. Hope to hear from you soon, and happy scanning.